Good morning, everyone. Uh, at the outset, I would like to thank the organizers for having me here. First lecture on a Sunday morning is always a difficult task, but nonetheless, we'll start. So, robo, friends, is a Czech word, and meaning of that word is forced labor. So, you are asking someone to work for you. That is the meaning of word robo. It has come from original word robota. So, robots are in use in multiple industries where you need precision, productivity, and efficacy. First time it was used in 1988 for neurosurgical biopsies, and same robot with some modification was used for prostate surgery in 1991. After that, many robots came in picture for abdominal surgery, oncosurgery, gynec, and but first time a robo for arthroplasty was used at Imperial College London, and after that, by Think Surgical California, a robo named Robodoc was used in 1990s, and current QVIS machine is, I think, from derived from this Robodoc machine. So broadly, these robots can be classified into imageless robots like Smith and Nevio or Corey from Smith and Nephew, and those robots which need some imaging, pre-op imaging, like QVIS from Curexo, Mako, and Rosa. But QVIS is only fully automated robotic system. So robotic surgery, it is bit controversial as of now. It is getting hold, you can say, but not yet accepted completely. But there is enough literature to support use of robo, at least in total knee replacement and partial knee replacement. So this study published in 2013, and they could found that there are no clinical differences in the clinical scores or complications when compared to conventional and manual technique. Another study published in 2011, and they found better alignment, accuracy of robotic TK and good clinical results achieved, and which may favorably influence clinical and radiological outcomes. Another study published in 2018, and they found there is reduced bone and periarticular soft tissue injury in patients undergoing robotic TK as compared to conventional jig-based TKA. So these studies, their consistent observation, you get better alignment, better placed implants, and which are going to definitely affect long-term survival in robotic, in arthroplasty. UK, the current literature overwhelmingly favor robotics as compared to manual. So you are planning to do UK, you must use robotic. That's the conclusion, at least in today's literature. So adoption of robotic technology is going up every year, and this chart shows that installation in US are going up every year, and this study found that, and predicted rather, that by 2027, 50% of total knee replacements will be done using robotic systems. So not just arthroplasty, but robo is here to play a role in various other orthopedic procedures as well. So QVIS is a fully automated robotic system where you need pre-op planning, and where you mark all these important bony landmarks like center of the femoral head and epicondyle, center of the ankle, which takes around 5 minutes. And your assistant, once they're used to it, they can do it, and pre-op planning for surgeon, and it is again a issue for debate in conferences, where why you want to waste the time for pre-op planning when you can do without image inside the theater. But this takes just 5 minutes for you as a surgeon. Once you are used to it, you get this chart at the end of planning, and then inside theater, robo calibration is done. This saved plan is loaded on the robo, and this goes on parallelly when your anesthesia work is going on and painting draping is going on. You have seen this surgery yesterday. So, and once the calibration and sterile draping is done, we perform the surgery. I'm not going to show you in detail because you have already seen it yesterday. But we have slightly modified the technique for pin placement. We are putting these pins inside the wound. earlier we used to put diaphyseal pins from stab incision, anterolateral aspect, which is the tension surface of the femur, and we are close to 1,000 knees now with this system. And with those diaphyseal pin, we witness fractures, and they happen 2 or 3 months post-surgery, not immediately. So with this metaphyseal pin, horizontal on the medial surface, nil, around 750, 800 cases now, no fracture at all with this, and which is extremely safe. So I will definitely recommend this to all QVIS users at least. So just like to share a couple of cases here. 74-year gentleman, and he was operated for fracture left tibia 14 years ago, and this is how he presented to us. Severe varus on the both sides, and so this is how it was inside theater. So very tight on the medial side, and in flexion also it was tight on the medial side. So I had to externally rotate the femur to match both flexion and flexion gap medially and laterally, and then increase the distal femoral cut to compensate for fixed flexion deformity. And so as you can see in this chart, video, I have increased the tibia cut by 2 mm, and externally rotating the femur. As you can see, these options are there. So the biggest advantage of any robotic system, you can visualize before you take the cut, how that joint is going to behave. And this precise planning, or this is precise balancing, is not possible with manual jigs. And so now I have balanced it to 10-10, and then since there was FFD, I have to increase the distal femoral cut, as we do it in manual technique as well. So I'm giving slight varus. Okay, it is to increase gap on the medial side. Okay, so as you can see there, here there was varus on the femur, and external rotation of the femur increased the tibial cut by 2 mm, and now I'm almost, it is balanced in, so in extension as well as in the flexion. So we finish the adjustments and we check. So now the gap is almost equal in extension as well as in the flexion. Then we are good to go. And this is his post-op X-rays. So just to sum up, this is actually pre-op and same patient post-op X-rays. So we can balance it beautifully. Same patient pre and post-op. We'll just run through these slides because of shortage of time. Severe varus, post-op, pre-op, video. Next day after the surgery, and same patient 3 weeks post-surgery. So just give me 2 minutes. Severe varus again, and tight medial side on the inflection as well as in the extension. And this is how we balance external rotating the femur, increasing the tibial cut, and increasing the distal femoral cut. Some varus in on the femoral side, and good balance. And this is his post-op X-ray. So friends, with robotic, again the argument is you cannot treat or manage severe deformity. But that's a myth. All severe deformities can be successfully managed with robotic system. And this is the last case I'd like to share with you. Valgus knee. So we, as an orthoplasty surgeon, we have been taught to externally rotate the femur to get good patellofemoral tracking. And so please note, this distal cut on the medial side was 13, up to 13, because big size femur, because severe FFD. And medial side it was just 5 mm, and lateral side I was resecting 9.4 mm. So I had to internally rotate the femur to balance the flexion gap. So now we are worried about the patellar tracking. So this is the same patient, and this is the patellar tracking you get. Okay, so complete correction of the deformity and good patellar tracking. So, and this is post-op X-rays. So pre-op and post-op video. So we'll conclude here. Many patients are there, but lack of time, I'll stop. So tips and tricks, distal femoral cut up to 12 mm for up to size C. Don't go beyond that because that it will be very close to epicondyles. Upper tibia cut, at least for QVC users, 7 mm because after that it literally soft tissues open out. Combined varus of 5, after that it is bit risky, that's what I feel. And then hide implant option on table is quite reliable to avoid notching of the femoral component. So we are close to now 1000 knees, and consistent observation is less drain, less pain. In fact, last around 500 cases, no drain at all, and shorter hospital stay. So don't doubt Robo's existence. It is here to stay. Thank you very much.
Thank you, sir. Our next speaker is Dr. Karthik D. Patel, sir. Kindly come, sir.